This was a difficult topic. I do not know how Dave comes up with these particular topics. So I went to the dictionary or Google or somewhere, and I looked up what this meant. And I thought it was quite interesting. And I think the meaning should say, a podiatrist rejected in podiatric love can be angry and dangerous. So that would be me. And I would probably say that I am. And this was a difficult talk, but it was very, very simple, and I'll summarize it before I actually get into my talk. I really don't like what I see as it relates to the team in America. I would tell you from my experience from 30 years at the county hospital in San Antonio and 7 years here in California, that every county hospital is a third world country in America as it relates to the diabetic foot. And you can probably say, well, how can Harkless say that? Well, I guess I'm corn like Dave said. I would say what I've learned is that the foot tends to fall between specialties in medicine. And whether you're the plastics, vascular, general, orthopedic, that's okay. But in 142 MD medical schools, podiatry is not there. And the fact that I spent a career there and I'm writing a book on my experience at the University of Texas, which I believe will be the forerunner to an Institute of Medicine study about who we are and where we fit in medicine. Medicine doesn't know that. And that's the biggest thing that I learned in my 30 years there in terms of the teaching-learning process, that nobody had a monopoly on knowledge, and that if you follow the revenue stream and who's in control, that's kind of what happens in healthcare. So when I arrived here, I went to two county hospitals, San Bernardino and Riverside, that did not have podiatry in the 21st century. Now I'm at both places, and I'm trying to start a residency with no money because there's competing priorities for starting the service. I am doing good work, but it's not what it should be in terms of the true, full, integration that's necessary, for the true team. I'm not saying that all those other particular disciplines aren't excellent and smart, but different things happen if you don't have the right team there working together, which most of you all are part of that. So I'll ask you all a question. How many of you all here in the audience utilize the international guidelines risk classification system in every note you have in your assessment? Could you raise your hand if you use it? Yeah, that's probably what I thought. So the reason I asked that is because I graduated 23 students last year in my first class. I gave lectures in endocrine section to the medical students and in podiatry and dentistry, and they all in combined classes, but I decided I would have those students back to find out were they utilizing what I taught them. And so there's a quote that says, just because you taught me doesn't mean I learned. Meaning that are you utilizing the system of care that's necessary? And what I found out when I brought them back in December of 12, that they'd been all over the country, rotating on all the major hospitals where there are podiatry residency training programs, but nobody was actually utilizing the system. And it wasn't until I spent a half day in the clinic with 7 students in a team that I was able to teach them and demonstrate to them why that was important and why every note should have something about where you are along the risk spectrum in the risk category system, because that tends to determine the outcome. And so thank you for letting me editorialize at the beginning of my talk. But that's the take-home message, that unless that change, there's no free lunch. Whether it's Medicare, Medicaid, the county hospital systems, depending on how they're set up in the various counties and systems, would depend on how that's taken care of. But we all pay for that. In Texas, it was all about my property tax. In California, it's probably part of the motor vehicle tax that goes into some of the county hospital systems that help us pay for that indigent, uninsured care and the population health that Dr. Sadawe so eloquently talked about. So teams reduce amputations. I think we all know that. There's good data to support the process. This is showing about a 46% increase for a risk for amputation. And it was actually decreased about 7.7 times after about 5 years of good team care. So when I look at the City of Angels, which Dr. Armstrong asked me to look at, these are the this is the largest healthcare system in America, is LA County. So you have the big county, USC. So most medical schools are associated with teaching hospitals. Generally, there's a county, and primarily the VA are the teaching hospitals, and then certain hospitals will have private hospitals that are part of the complex. But those are the they have the resources that are necessary to provide the competencies for the healthcare delivery system, which includes a huge educational system, including everybody. But you also have Ranchos Los Amigos in Downey, which is USC, Martin Luther King, which is UCLA. You have Olive View, UCLA, which is in the San Fernando Valley, Sylmar, Harborview, which is in South Bay and Torrance. And you have several fairly qualified health centers and also some outpatient clinics. And then you have this private system like Dr. George Andros has with Valley Press, and you have a lot of wound centers. And my question with the wound centers would be, do they follow the same protocol that I asked you, and how well do they do that in terms of looking at the outcomes? But this system here have the people that are the sickest with the most comorbidities that are the probably most difficult to take care of. And so the flagship here would be Olive View, UCLA. Dr. Jones, my academic dean, moved from San Francisco to Los Angeles in 1997 and was hired to integrate the Greater Los Angeles VA healthcare system residency program. But someone asked him after he started there and was doing a great job, would he consider going to Olive View, which had some podiatrists there, but they really wasn't part of the academic team. So over that time, from the time that Dr. Jones left and started the clinic, you can see the growth of the podiatry service here over the last, say, 15 years almost. And you can see here that they're seeing about almost 11,000 patient visits, 10,000 patient visits a year, and about half of these particular patients have diabetes. So this particular clinic growth parallels my clinic growth when I was at the county hospital in San Antonio. At my peak, we were seeing about 13,000 patient visits and about 300 admissions to my service, and we cut the amputation rate in half, and that's where Laver and Armstrong and Steinberg and all those people came and worked with us that had more knowledge than I did about research and writing, so that we actually created a great team and how we were able to do that. So I'm surmising that, again, this is what really needs to happen in every system. So I mentioned the Inland Empire and what I've started. So my biggest concerns at Riverside is that I'm in the wound clinic. I'm working with the chief medical officer, who is a cardiothoracic surgeon who's excellent. He's totally embraced me, but there's no space. And so I'm still working out of the clinic and probably seeing 20, 25 patients with other types of foot problems in addition to some diabetic foot types of issues. But I will tell you that the need is the same as it is in that system where you saw that growth from Olive View, UCLA. And so what happened was they were so much in the red that they called in a healthcare company called Huron Medical. That's a turnaround company. And so now I have someone that's listening to me. They terminated all of the leadership of the hospital, probably November. And so I'm optimistic with population health, with the Affordable Health Care Act, and everything that Dr. Sadawe tied together, that they really understand the importance of allowing us to become a true team so that we can grow the service and do all the things that you know about the outcomes that you can derive from good care. So interprofessional foot and ankle care is important in integrating overlapping and complementary specialties. And nobody has monopoly on knowledge. God put us all here to unify, to work together, to serve, to make everything better. And if we understand that and our ego doesn't get in the way and we understand the roles that everybody play, then clearly we can reach the outcomes that the Affordable Health Care Act would like for us to accomplish. So the academic mission is as significant as the clinical care mission. And so we need to teach the students, residents, fellows, the faculty, and everything in that particular process. So if you go to 142 MD medical schools this week, you'll have case conference, grand rounds, or a combination of both every week. And that's how everyone is held accountable for the rigor and relevance for that growth. So we have the PAs, nurse practitioners. I just read from 2 days ago from our senior vice president. We have a fellow review, and he was looking at Obama's budget, and I think he had about $4 billion in there to go into the National Health Service Corps to train more primary care physicians, nurse practitioners, et cetera. to take care of the growth that's taken care of with that's taking place with the Affordable Health Care Act. Now, podiatry has a shortage of residency programs, and so that's a huge impact, and that should be an economic generator to help us move forward. But in the Riverside piece, Riverside started a new medical school. There's a new private medical school that's opening up across the road from Arrowhead Hospital in San Bernardino County. So you also have competing priorities for new medical schools that are opening up that have to have rotations, for their students. And so those are all the challenges that we have in the barriers to success. So we mentioned this, cradle to grave learning, lifelong learning, and so this is what the academics does. So what are the barriers to success? Cultural, their education. So if you go into a medical school, they tend to work in silos, they tend to be departmental, and depending on what the revenue stream is, will depend on whether they want you there or not. And if you're talking about the friendly orthopedic surgeon, he's the reason that podiatry is not integrated into the mainstream of medicine. Probably for the wrong reasons. I happen to do some foot surgery, things that they may do, but nobody's going to trim the corn, cut the callus, pad the shoe, look inside the shoe and do that with passion and understand the mechanics of why it all develops and being able to teach that to everybody on the team. Because if I don't teach the nurse practitioner, the PA, the primary care physician, residents and interns at every discipline rotating, we're not going to make an impact in this process. But that's what needs to happen, and that's what needs to integrate. And guess what, Dr. Bolton, if I could get to Obama and have him to sign what they call whatever he does to executive order to help me do this, then we could coin everybody and move forward. Thank you, Dave, for letting me say that. Politics plays a role in everything. Politics is who gets what, when, and where, and how come. And so you have to be involved in the process. I was recently in Sacramento on the 5th. We had a legislative day. Podiatry was eliminated from Medi-Cal. Nobody even takes Medi-Cal. So for me to go to the county hospital to start, I can't start because I'm not generating any money. And my provost is giving me a hard time saying I'm using my tuition dollar to train my students instead of getting some clinical dollars from the county hospital, which means that nobody values me. There's no love, if that makes sense, because of the money. And I talked about the financial part. So, but I did meet Gavin Newsom. Gavin Newsom sits, he's the Lieutenant Governor of California. And matter of fact, he just sent me a personal note. I can't believe he sent me a note. I must have made an impression on him. But this is my letter from Gavin Newsom. So hopefully, since he sits on the Regents, we'll be able to get a little money through Brown. Hopefully I can get $1 million so I can go to Kern, Bakersfield, Fresno, and other counties that I've visited. And I've seen the same thing there when I visited. Not if I visit once, I visit each one of those places at least 2 or 3 times, talking to some of the leadership, getting some data about what's going on in those particular hospitals. And as you know, as goes California, as goes the nation, some people may agree with that, not agree with that, but I think that that probably has some significance. And hopefully if we can develop this particular initiative and move it forward, then we can be more successful in prevention. So the ingredients for success are cooperation, communication, mutual respect, trust, and collegiality. That's so important in that growth. And so when we look at the population-type health, the Institute of Medicine said patient-centered care is care that is respectful and responsive to individual patients' preferences, needs, and values. And it satisfies the Institute of Medicine triple aim: improve population health. Again, Affordable Health Care Act this is the main piece in every major medical school, and they're changing the curriculums in terms of how they teach, looking at the population versus patients just individual when they're sick. And patient satisfaction and cost. So cost and quality are the 2 major issues that's driving these particular changes in medicine. So what does this mean? Providing the care that patient needs in the manner that the patient desires at the time the patient desires it. And it's the right time and that particular aspect. So how do we commit? By communicating, sharing, decision-making, evidence-based guidelines, timely access to care, transparency and accountability, safety, and we need to measure, improve, and measure. That's important. Hopefully the electronic medical record will help us and allow us to do that in that regard. And Don Burrick, who was the initial leader of the CMS changes, said that we should behave as guests in the lives of patients instead of hosts in the healthcare system. I think I've done my 20 minutes. Is that right, Dave? Do I have 1 minute or 2? 1? Well, I'm going to go through 5 slides in 1 minute. Why is the diabetic foot complex? Because of heterogeneity. Take this slide home with you and make it in a chart, put it in your PDA or your thing, and look at every patient you see, And when you miss something, it'll show up on this, that you need to evaluate to be sure that you've been comprehensive. This is why you need a team. That's why you need interprofessional care. That's why you have to have follow-up. That's so important in everything that's necessary. History and physical informs the system of care. Not bad people, but bad systems. We have validated risk system. That's why I asked you where you're utilizing it. So I hope that you would get the system and utilize it. And this is how it happens, the translation of knowledge. Once we know that it's good, and you have had the randomized trials to delineate that, is it available and is it being distributed? Sound like we know what the risk system is. It's available, but it's not being distributed. We're not using it. So what do we need to do to utilize it? That's the big challenge. So this is a task force on the comprehensive foot examination and risk. These are the risk categories from the international system. 0 is no neuropathy, 1 is neuropathy plus deformity is 2, and history of pathology. Again, this is what you should write in your chart on every patient with diabetes. They have to be screened. So if we do massive system screening, we pretty much will know where those patients reside. And Lavery did some great work demonstrating that 55% of patients will recur after 3 years in category 3. That's if they've had a history of a previous ulcer and amputation. And he also demonstrated that this cost provided about 80% of the cost was in category 3 in this cohort of patients that he followed up for about 3 years. And he published this in Diabetes Care in 2003. So again, we have the data to show that we have the risk system, but again, as I asked you earlier, how many are using it? You're not using it. So please go back and use it. And please get involved in the system so that we can get better care in the process. And this is Kavanaugh's work by linking the risk factors. This is where a good podiatrist come in on your team, understanding the structure, function, footwear, and lifestyle, and coordinating those particular aspects in terms of how may recurrence be prevented.